On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
The next will be a presentation by Dr. Elizabeth Magnuson from Kansas City to talk about the cost-effectiveness analysis from Freedom.
Thank you very much, Dr. Antman, ladies and gentlemen. It's a great pleasure to be here this morning to present these results from the economic study for the Freedom trial. As Dr. Fuster already presented, clinical results from the Freedom trial showed that for patients with diabetes and multivessel coronary artery disease, CABG, as compared with PCI using drug-eluting stents, was associated with significantly lower rates of death, MI, or stroke, with the benefit driven by significant reductions in both death and MI. This prospective economic evaluation was carried out alongside the Freedom trial to provide additional insight into the relative value of CABG versus PCI in the drug-eluting stent era from the perspective of the U.S. healthcare system. As Dr. Fuster already presented, there were 1,900 patients randomized in the Freedom trial, 947 to CABG, 953 to PCI. There were 36 patients in the CABG arm and 9 patients in the PCI arm who underwent no index procedure and withdrew from the study early on within the first week. Therefore, there were 911 patients who did undergo revascularization in the CABG arm and 944 patients in the PCI arm, and these form the patients for our economic study. We treated these patients according to the intention to treat principle, even though there were 18 crossovers to PCI in the CABG group and 5 crossovers to CABG in the PCI group. And median follow-up time was 47 months for both of these treatment groups. So the primary endpoint of our economic study was the incremental cost-effectiveness ratio expressed as cost per quality-adjusted life year, or QALY, gained. And costs and quality-adjusted life years were discounted at 3% annually. Our approach to the analysis was a two-stage one, starting with an in-trial analysis based on observed survival, health state utility, and costs derived from reported healthcare resource use during the trial period. Following that, we carried out a lifetime analysis based on projections of survival, quality-adjusted survival, and costs beyond the trial period. A little bit about our costing methods. This was a prospectively designed study with detailed resource utilization collected for the index procedures and throughout the follow-up period. Cath lab and CABG-related procedure costs were based on measured resource utilization and current unit costs, and we applied a cost for drug-eluting stents of $1,500 per stent. Even though this was an international study with patients enrolled from 18 different countries, we were careful to apply costing methods that were not influenced by the length of stay, which can vary across different healthcare systems. And our cost analysis considered not only costs associated with the index procedure, but costs associated with all cardiovascular and non-cardiovascular rehospitalizations during follow-up, physician fees, outpatient cardiovascular care and medications, cardiac rehabilitation, and nursing home stays. This slide presents an overview of index procedure resource use. These were complex patients. Indeed, in the patients randomized to PCI, about a third of them underwent staged procedures with 2 or more procedures in the cath lab that they underwent. There were 4.1 drug-eluting stents implanted on average per patient. Considering just the procedure costs alone, there was an incremental cost of roughly $3,000 for patients treated with PCI or within the PCI arm. While the PCI costs associated with the PCI procedure were higher, over the course of the index hospitalization period, there were higher costs for the CABG arm due to the prolonged recovery period and complication rates that occurred in that arm. And the physician fees were also higher for CABG. And what this rendered in terms of a cost difference was a $8,600 increase in costs for patients in the CABG treatment arm. And that was highly significant. Over the course of the 5-year follow-up period, however, there were higher rates of resource use in the PCI arm, largely due to repeat revascularization procedures, and these are shown here in terms of rates per 100 person years, and also rates of cardiovascular hospitalizations were higher for patients in the PCI arm, and significantly so. There was no significant difference in the rates of non-cardiovascular hospitalizations. This slide shows annual costs as well as cumulative costs over the 5-year period. The bars with yellow representing CABG and blue representing PCI show that during year 1 there was very little indeed difference between follow-up costs overall, slightly favoring PCI during year 1, but from year 2 and forward there were higher costs during follow-up in the PCI arm, and the incremental costs for the PCI arm tended to increase over time, such that the cumulative costs, which started out at the end of year 1, roughly $7,900 higher for CABG, they decreased over time such that at the end of 5 years, the cost differential was roughly $3,600 higher for CABG at the end of 5 years. Turning attention to the life years gained and the quality-adjusted life years gained during the trial period, because of the increased mortality rate for CABG early on in the recovery period, life years gained did not become apparent until year 4 of the follow-up period, and at the end of 5 years there were roughly 0.053 life years gained with CABG. Considering quality-adjusted life years gained, because the recovery period after CABG is associated with lower quality of life, indeed the quality-adjusted life years gained with CABG did not emerge until year 5. We developed a Markov model to project the post-trial life years, quality-adjusted life years, and costs over the lifetime of the patient. And we did this by estimating the monthly risk of death based on age, sex, and race-matched data from life tables, U.S. life tables, that were calibrated to the observed 5-year mortality during the trial for the PCI population. We estimated the CABG effect based on a landmark analysis for using data from years 2 through 5 in the trial, where we obtained a mortality hazard ratio for CABG versus PCI of 0.6. In our base case analysis, projecting forward in time, we assumed a gradual attenuation of that CABG effect, whereby the mortality hazard ratio increased from 0.6 to 1 in a linear fashion between years 5 and 10, with no impact of CABG assumed beyond 10 years. And then we applied long-term estimates of costs and utility weights derived from regression models fit to our trial data. This graph here shows the in-trial survival period, experience through the first 5 years of the trial, and then our projections over the course of the lifetime. The area between these two curves represents the life years gained with CABG. During the first 5 years, we have, as I mentioned before, 0.53 life years gained with CABG, but over the course of the follow-up period, we get an accumulation of life years gained, largely due to that higher rate of death and the life years lost due to the higher death rate in the PCI arm, such that at the end, taking a lifetime perspective, there were actually 1.266 total life years gained with CABG. Now I'm going to present the results of our lifetime cost effectiveness analysis. We use this cost effectiveness plane to present results such as this, where the x-axis represents the difference in quality-adjusted life years, and the y-axis represents the difference in long-term costs. So this red point in the upper right-hand quadrant corresponds to the incremental costs over the lifetime of CABG of roughly $5,400, and the combined with the incremental gain in quality-adjusted life years of 0.66 years. As a result, we get a cost-effectiveness ratio of roughly $8,100 per quality-adjusted life year gained with CABG. Shown here is a bootstrap distribution around that estimate, and we see that over 99% of this distribution lies below and to the right of the line representing a $50,000 per quality-adjusted life year gained, which is a benchmark for considering a treatment cost-effective, and indeed our estimate is very well below that. So CABG was, according to our assumptions here, a highly cost-effective therapy. We carried out several sensitivity analyses. This one I'm going to present was our most conservative, where again, this shows the observed survival for 5 years, and then the projected survival, assuming no CABG benefit beyond the 5-year period. Under this assumption, we estimated 0.754 total life years gained with CABG, and an incremental cost-effectiveness ratio of roughly $27,000 per quality gained. And again, this even conservative estimate of the CABG effect renders CABG a highly cost-effective therapy. We also carried out subgroup analyses based on syntax score, and they all yielded cost-effectiveness ratios that were favorable, even at the low syntax score, while the incremental cost of CABG was quite a bit, tended to be higher. We got an estimated ICER, or incremental cost-effectiveness ratio, of roughly $22,000 per life year gained. And for the other syntax score tertiles, the estimates were highly favorable. We carried out several other subgroup analyses, and for all of them, including stratifying patients according to sex, age, and U.S. versus non-U.S. enrollment, all of the results were highly favorable to CABG. So in summary, we found that CABG is indeed associated with initial costs of roughly $9,000 per patient higher than PCI. These costs are partially offset by lower costs associated with repeat revascularization and, to a lesser extent, cardiac medications. At 5 years, CABG was shown to improve quality-adjusted life expectancy by roughly 0.03 years, while increasing total costs by $3,600 per patient. However, over a lifetime horizon, CABG was associated with 0.66 quality-adjusted life years gained and a roughly $5,400 per patient higher costs, yielding an incremental cost-effectiveness ratio of roughly $8,100 per quality gained. Our results were robust to a broad range of sensitivity analyses regarding the duration of the CABG effect on both survival and costs, and the results were also consistent across a wide range of subgroups. So in conclusion, for patients with diabetes and multi-vessel coronary artery disease, CABG was found to provide not only better long-term clinical outcomes than PCI with drug-eluting stents, but these benefits are achieved at an overall cost that represents an attractive use of societal healthcare resources.